At MedShield Medical Scheme, we don't just talk health, we do health. SMS MedShield to 33023 or talk to your broker to get your kind of care.
Inspired by the many actions taken by many South Africans from all walks of life over many years to fight AIDS. Thank you to your efforts. We have the biggest HIV treatment program in the world, with nearly 3.5 million people on life-saving anti-retrovirals. We are bringing care and treatment for TB to the doorstep of vulnerable populations in correctional services and mining towns. Today, South Africans are living longer and have more productive lives. Fewer people are dying from AIDS and TB. We have dramatically reduced mother-to-child transmission of HIV. This has been made possible because all of us have worked together.
So South Africa is said to have the highest population of people living with HIV in the world. According to the UNAIDS statistics, just under 7 million South Africans currently live with HIV. And as we just heard from the Deputy President, we've achieved some successes in combating this epidemic. However, there are still some challenges. So today we focus on HIV and AIDS. We explore where we come from with this epidemic, what the current challenges are, and what the future holds for us. We'll also look at this new vaccine trial launched just a few days ago. And joining me in this discussion is an expert panel consisting of the Executive Director, HIV, AIDS, STI and TB Program at the Human Sciences Research Council, Advisor to the Deputy President of the Republic of South Africa, an HIV and AIDS activist, and the Director of the Perinatal HIV Research Unit at Chris Hani Baragwanath Hospital. So sit back, relax, and learn from this exciting show ahead. Please join us again with your questions or views at Johannesburg 714-6841, 6842, or 6843. You can also tweet us at SABC Health Talk, or simply just interact with us on our Facebook page, SABC Health Talk. I'm Dr. Sello Mutaung, and this is Health Talk.
The first case of HIV in South Africa was recorded in 1982. This was to be the start of a long and painful journey for thousands of South Africans infected with the HIV virus or had full-blown AIDS, who succumbed to the disease over more than 30 years. In 2009, the government declared HIV and AIDS a crisis, and plans were put in place to respond rigorously to stem the tide of infections and to provide treatment for HIV-positive people. With effective HIV treatment and a managed delivery, the risk of mother-to-child transmission has been greatly reduced. Gogetso Moketwa is one of the 67% HIV-positive mothers who are now giving birth to uninfected babies.
I was diagnosed at the age of 9, which is in 2000. And I didn't really understand what was really HIV. I only knew and understood at the age of 13. I didn't take it well.
Partner who's HIV negative decided to fall pregnant, something that was unheard of more than 30 years ago.
My daughter's name is Karen Moketwa. She's 4 years old. She's HIV negative. I planned actually my pregnancy. I spoke to my doctors about my status, and actually my doctors, they explained to me the importance of my treatment. I knew that since then, and I still continue with it. So when I planned her, it was with her father that's also HIV negative at this point. That's my boyfriend that I'm dating at this point in time.
And treatment, some people are still fearful and keep their HIV status a secret.
We still have the stigma around the communities, family, people that's supposed to be supporting you. So it's really affecting a person that's HIV because we need people around us, like anybody else needs someone. So the support is really more important. So if there's stigma already, it's not going to be possible for me to come out or disclose or talk about my status or even live a healthy life.
Living with HIV and AIDS allows people to seek counseling and treatment. For 25-year-old Gogetso, it gave her purpose to live her life fully.
Being HIV positive, one thing that I've learned, and I'm glad that I'm HIV positive, is because of every day changes. Every day is exciting for me because now I have a reason to live. I have a reason to stay positive. So that goes for anyone else. If you know that you're HIV positive, just have a positive mindset.
An estimated 7 million South Africans are living with HIV. Although people are now living longer because of treatment, government and health authorities are still concerned and working hard to reduce the number of infections.
So here to tell us a little more about this HIV/AIDS story, it's a great pleasure to welcome, first up, Dr. Nono Simelela. Dr. Nono Simelela is advisor to the Deputy President of the Republic of South Africa. And I might as well just add that she is the chairperson of the 7th South African AIDS Conference, and in fact is the first CEO of the South African National AIDS Council. Welcome to Health Talk, Dr. Simelela.
Thank you. Thank you very much.
All right, and of course, another usual guest on our show. We've had him more than once, Professor Geoff Setswe. Professor Setswe is the Deputy Executive Director, HIV/AIDS, STI and TB Program at the Human Sciences Research Council, HSRC. Welcome to Health Talk again, Prof.
Thank you, Doctor.
All right. Perhaps let's start with you, Dr. Simelela. I mean, I think everybody now knows what HIV and AIDS is. Perhaps in 2 sentences, what are we talking about?
Well, we're talking about an infection caused by a virus that people now know that unfortunately becomes a lifelong infection. Mm-hmm. But fortunately, you know, with all the advances in science and technology, people now can have treatment and be able to live productive lives.
All right. We just said, I mean, the Deputy President also referred to this, that we've had some major successes. Perhaps let's just track back a little bit, go back, and just kind of give us a sense of where we come from with this problem.
I mean, I think for many young people who see where we are today, they wouldn't believe, people like Professor Setswe and a few others who've been in this field long enough know that there was a time in this country when we didn't have treatment at all. So we had a lot of people dying from HIV and AIDS. We had a lot of babies born infected. Transmission rates were high in the region of 39%. And now we've reduced that to almost less than 2%. So we really, truly can say as a country, we are on the path to where we will have babies born free of HIV.
Okay.
So that's one of the biggest successes.
All right.
Then to know that people no longer die. I mean, there isn't a country in the world that has increased life expectancy by 4 years in a space that we have done. It's a very short time frame to increase life expectancy and to have such a big program. It's incredible, you know, from no patient on treatment to over 3.5. We've got another 200,000 patients in the private sector, taking that number to 3.7.
Okay. So. Can you, well, in that sense then, perhaps just from a government perspective, just remind us in terms of what targets we've set ourselves, you know, insofar as eradicating this problem?
Well, I think we need to be aware of the fact that we will never really eradicate this epidemic. We are looking at a situation where there is more people on treatment than the number of people getting infected. We set a target of over 4.1 million people on treatment by the end of 2017. And we want to get to a point where everybody who's HIV positive gets treatment. That is why on the 1st of September, as the Minister had announced, people who get tested and are positive are provided treatment.
Prof, perhaps let me invite you in here. Obviously, I mean, we're looking at having this AIDS-free generation in years to come. But surely there are some challenges that we currently face. And perhaps before we start our discussion into the challenges, what is the picture looking like in terms of prevalence and incidence? And perhaps for the sake of our viewers, if you could just tell us the difference between prevalence and incidence, because oftentimes we use the terms interchangeably.
Yeah, the prevalence talks about the number of existing cases of a disease, which means all people who are infected with the disease, whether they were infected 20 years ago, 5 years ago, or yesterday.
Right.
And incidence talks about the new cases of a disease. So incidence specifically is people who are infected probably in the last 6 months or so.
Right.
We've got technology that is able to determine whether someone was infected recently or not.
Right.
But we can also do what we call modeling. That if we had done a study 3 years ago and it showed that there were so many people who were infected with HIV, now we have so many, we can also estimate through modeling that the incidence now, the number of new cases is that. And this is where South Africa has done very well in incidence, reducing the number of new cases. What we don't expect to see is to see the prevalence going down,
of course,
because people are living longer,
right.
And if the prevalence was going down, we would be worried that people are dying and the epidemic is burning itself. But what we want to see, and this is what the target of the new National Strategic Plan is, to reduce new incidence of HIV/AIDS. But
and this is where the problem is, isn't that?
Yeah.
Perhaps let's talk specifically about that, to say. Clearly, I mean, the ideal is to say, okay, prevalence stays where it is, but incidence drastically come down. How well are we doing in that regard?
The incidence is going down in overall.
Right.
We have seen a reduction from 370,000 maybe in 2011 to around 270,000, a reduction of 100,000 overall. But there is a target group, age group 15 to 24, where the incidence is not going down. This is young women and girls. This is the specific group where we need to make a difference, because if you have a 15 to 24-year-old who gets infected, and you have many of them, remember they're going to live a lot longer with HIV/AIDS, and therefore the prevalence will still show that we cannot drop down.
So what you're saying is, even in terms of the incidence, when you're looking at different age groups, the age group that has the highest incidence is the one that you're referring to, 15 to 24.
It means these are new entrants into the HIV/AIDS epidemic,
right.
Because we've got a big bowl here of people who were infected many years ago, who are on treatment, who are living, and then you have new people coming in. Right. We don't want to add people into the bucket. We want to stop the epidemic. We want to stop the tap, so that you don't have new infections coming up. And that is why we need to have specific interventions targeting. Now, we use the word, the expression 90-90-90, meaning that to be able to have an AIDS-free generation, we want to get 90% of people knowing about their HIV status, 90% on treatment, and 90% are virally suppressed, meaning that if they are virally suppressed, they cannot transmit the infection to other people in society. If we're able to achieve that, then we're able to stop the new infections coming in. Even those people who are infected, even if they sleep with uninfected people, they would not infect them, because the treatment is working so well that it has suppressed the virus.
In fact, perhaps this is just a good point to break, because I'd like us to then focus on just that high-risk group to kind of have a sense of what the actual problems are. But that after the break. So after the break, we look at the impact of HIV and AIDS and dwell a little more on risk factors for transmission. Please stay with us.
MedShield Medical Scheme, we don't just talk health, we do health.
It's so good, nothing else can replace just your slightest embrace. And if you only would be my own for the rest of my days, I will whisper this phrase, my darling, c'est bon.
We make sure to be where news is happening,
both locally and globally. For the latest business news, stay with us.
From South Africa to the world, we've got all your latest sporting news.
Don't miss our weather updates every hour.
Stay tuned to News Today, Monday to Friday, from 3 to 5:30 p.m. here on SABC News.
MedShield Medical Scheme doesn't just cover you when you're ill, we'll help you stay well.
Welcome back. We're talking HIV and AIDS today, and with me in studio is Professor Geoffrey Setswe, Deputy Executive Director, HIV, AIDS, STI, and the TB program at the HSRC. And we're now joined by another special guest, Notyatyambo Makapela. And Notyatyambo is an AIDS Council member in the Ekhuruleni district. And yeah, she's done quite a lot of work around HIV, AIDS, campaigning, advocacy, treatment literacy, and a whole lot more. And perhaps I shouldn't be saying all of this. She will tell us about exactly what she does. Notyatyambo, welcome to Health Talk.
Thank you so much. Thanks for inviting me.
All right, perhaps let's try and understand who you are, what you do, and what you do for HIV and AIDS.
Okay. My name is Notyatyambo Makapela, original from deep rural areas of Eastern Cape, based in Johannesburg. I am also a woman who's living with HIV, living openly about my HIV status. And I am a woman who has done a lot of work, and especially after I was diagnosed as a young person. And also I'm on treatment. When we are talking about, you know, the theoretical part of living with HIV, I know it practically. Because
when were you diagnosed?
I was diagnosed in 2005, 6th of January, after a long sickness. I was diagnosed because I had PCP, and my CD4 count was 0.8. I was full-blown with the weight of 28. So I was introduced immediately on treatment. And then after that, it's when I was introduced to go and join the support group so that I can seek and get more support and understand, you know, HIV. And then fortunately, this is when I was introduced to Treatment Action Campaign. Because of the long waiting list then to start treatment, my parents had to take me to a private doctor where I started using the dual therapy instead of triple therapy. I didn't have that information until I joined Treatment Action Campaign. So I was referred by my doctor to public hospital. And then I was scared because many people were dying and they didn't afford medication. I think that is one of the things that made me to be open and give hope to people who are voiceless, and also to make sure that government is doing much more in making sure that there is access to treatment.
So what prompted you to come out in the open? I mean, firstly, what sort of impact did this have on you personally?
I think for me, I didn't have a choice not to tell about my HIV status. You know, when you are in a stage, you are so sick, and already community has assumptions. They disclose on your behalf. So I think for me, it was just to confirm, as to say, okay, you've been talking. Now I am living with HIV. So what? So at the same time, I saw many people who were dying because of the stigma and discrimination. Even within my family, died without even telling. Remember, I'm from rural areas, and this stigma is so much high as compared to Johannesburg. So I think I had no choice. I had to just make sure that community knows about it. And I wanted also to prove a point that, yes, I am living with it. I am going to learn about it, and so that I know what treatment does to my body to suppress the virus that I'm living with. And then that was one of the reasons, and also to educate and raise awareness to so many people out there.
All right, we're going to be talking just about, the high risk, the so-called high risk group. And I'm going to ask for your opinion in terms of what it is that is actually driving, new infections. But perhaps let's just get a sense again from Professor Setswe. Prof, we spoke earlier about this, age group between 15 and 24, and I presume we're talking mainly females. What could be the problems? Let's just look at what is it that drives, high rates of infection, especially in this vulnerable group.
I guess the age group 15 to 24, this is what we call adolescent girls and young women. They are the most wanted group. I think they are getting into sexual relations with men who are aged 8 years and above, and are also getting into relationships with older men who may be 50 and above. And there are many social factors why young women would get into risky sexual behaviors, because power relations between men and women in the first place, and secondly there is education, issues of poverty, inequality, so there are structural, social, and other factors. And you now have heard recently about Mavuso, where women come into a setup where there are men, and there is money that is being exchanged in the process. And sex work is also involved. This is the age group that is more likely to get involved in sex work because it is related to poverty. People want money to get education, to get their life going on, and things like that.
It's interesting you talk about poverty and education, but this is a problem that cuts across all education strata, so to say. I mean, recently we had heard about, university, young women at university actually, trying to get fees, or at least money to pay for fees and sustain themselves, by actually selling their bodies. Your comment on that?
Yeah, there is transactional relationships that are happening because people know what they want in life. They may want education, and there is this struggle not to get money somewhere. And if you don't get money, someone gives you an advice that you can get into get a relationship with someone with money. So where you have an unequal society, you've got some people who are very rich, who have got a lot more money, and you have people who need basic things in life. You are likely to get these kind of things. And in some cases, it goes to an extent of full-blown sex work where someone says, I want to survive. It is not because they like it. It's because they want to survive. They want to make money from somewhere. And in the process, they're exposed to the risk of HIV infection.
Right. Notyatyambo, let me get your views on this. I mean, this power play, we now hear of the so-called blessers and so on. I mean, your views on that as being a risk factor for transmission?
Okay. I think for me, the fact that HIV is still having, a woman's face, and yes, we are vulnerable because of different reasons, as Professor has said. I think one of them is the biological factor, the way that we are made up as women. And also, I think for me, it's with regards to the access to prevention. We still have people who are owning our bodies as women. We can't make decisions irrespective of your financial status. You can be a powerful woman with money, but there are different reasons why as women we become so submissive at some stage. And then when it comes to, young women being vulnerable with the age group that we are talking about, I think it differs from one person to the next, because you may find some of the young girls who are coming from, backgrounds that have money and so forth, but they still choose to do that. So for me, I think it should be the question of, if we are talking about blessers, are all the people who are transacting to get money poor? Because for me, I think we still need to do basic work, which is research, before we can come up with anti-blessers campaigns, because we're going to waste money only to find out this is not the only reason, financial status, that makes these women to choose. Because you may find that women are making their choices because even though they are working, they've got salaries, but they still do the transactional work.
Very interesting. But, perhaps let's get Kim on the line. Kim from Johannesburg. Welcome to Dr. Kim. Ken.
Good morning.
Ken, are you there?
Yes.
Your comment or question, please.
Yeah, so I wanted to find out, first of all, good morning.
Morning.
I want to find out, there are two partners, right?
Yes.
One is positive, the other one is negative. So I want to find out if they meet each other without using a condom, while the last test they had, the viral load was saying undetectable, all right? What are the chances of the other partner being infected? And the second question, I want to find out, is there anything that can happen to the partner who is positive that will trigger the viral load to go up again? And the third question, I want to find out also because now the partner who is positive is on using a tribus as a treatment, medicine for treatment. I want to, is there any other medicine which is better than tribus?
Sorry, I didn't get that. Using what medication?
Tribus. They call it tribus. Tribus or tribus, yes.
Okay.
Yes.
All right. Okay. Very interesting questions. I think these are questions we will try and tackle after the break. And just maybe to quickly make a note, firstly, you want to know about a situation where one partner is positive and the other one is negative, the chances of transmission. And secondly, you know, on the issue of the effect of the viral load. You know, whether or not it's got any effect on that, and of course the issue around tribus on treatment. Did I summarize that correctly? Right. We probably will try and, you know, answer these questions just immediately after the break. But for now, let me thank Notyatyambo Makapela, Ekhuruleni AIDS Council member, Prof. Geoff, Setswe, Deputy Executive Director, HIV/AIDS, STI and TB program. Thank you so much for your time. All right. When we come back, we now talk prevention, and of course we'll answer Ken's questions after the break. Stay with us.
MedShield, embracing our members in good health since 1968.
Africans are coming up with innovative tech solutions to solve their challenges.
We developed mobile apps that gamify the learning.
On Network, we have information about Africa's technology and social media landscape.
First rate, I think there was less than maybe 2,000 visitors. And now this year we're expecting around 35,000 visitors.
We also tell you about apps celebrities are using.
My favorite piece of technology right now, I would say it's M-Pesa.
That's Network with Ms. Simelela Zondi every Sunday at 7:30 p.m. Central African Time.
If we're talking health, then let's talk seriously.
The first study of...
Welcome back. Now, we having a slight technical challenge with that. We'll come back to that. Perhaps let's see if we can have a look at it now.
The first study of its kind in 7 years, the HVTN702 vaccine is expected to end new HIV infections in South Africa. The vaccination is tested on HIV-negative participants. Scientists say this is the most advanced clinical trial. If the vaccine is safe and effective at preventing HIV infection, half of the participants will be vaccinated with the HVTN702, while the rest will use a placebo, almost equivalent to water when compared to the vaccine.
So what the vaccine does, it allows the body to attack the virus. It generates the antibodies that are required.
For young people like Lorna Jack, this is an opportunity to help find a way to decrease HIV infections in the country.
I heard about the study from a friend of mine, and I decided to come on the site and to gain more information of what is the site about and what's happening. So I came and I heard that the site is about researching for a cure for HIV and AIDS. So I decided to join because I'm quite a helpful person and I want HIV and AIDS to be cured one day in the next coming future.
All participants are aged between 18 and 35. This age group is most prone to HIV infections.
From the data that we have, we know that we have about 1,000 new HIV infections in South Africa on a daily basis. And we know that most of these new infections are concentrated in the youth. So such a vaccine study would be important for our youth out there.
The participants will be monitored quarterly for the next 4 years. And if the trial yields more than 50% efficacy, it will then be open to a larger population. There are 15 sites across the country which will provide vaccinations, and researchers say this trial is a step closer to finding an HIV vaccine. Lopang Alamu, SABC News.
Right, we're going to learn more about this vaccine and perhaps other prevention methods. And perhaps let me, at this stage, welcome another special guest to my panel, Dr. Fatima Lahe. Dr. Lahe is Director of the Perinatal HIV Research Unit based at Chris Hani Baragwanath Hospital. Welcome to Health Talk, Dr. Lahe. And of course, I still have Dr. Nono Simelela, Advisor to the Deputy President of South Africa. But before we start our discussions, we have a question to answer from Ken, but let's take another one from Rebecca from Twana. Rebecca, welcome to Health Talk.
Yes, good morning. I just want to find out that what is the normally you go to a specialist and they prescribe you a certain drugs based on your conditions, and the medical aid will reject that medication that you're being prescribed from the specialist. What is the government doing? Because normally we find that this medical aid they want to give us a cheaper drugs that can cause complications to the patient.
Yeah, I'm not sure if I had, your line wasn't too great. I'm not sure if I had the question at the beginning. Can you just repeat that?
I say you go to the specialist.
Yes.
They prescribe you the drug which is related to your complications based on HIV.
Yes.
Now that the medical aid is declining that drug.
What do you know the name of the drug? What drug is that?
The Stevia.
What is that?
IEXA, that's the name of the drug.
IESE.
XI.
All right. Okay. Rebecca, I'm going to ask you to please just send your question via Twitter or something, okay? So that at least we can try and respond to your question. But, Ken asked the questions a few minutes ago around, perhaps let's just talk the principle. I mean, the line unfortunately isn't very clear, but the first principle is around a partner who's HIV positive, having unprotected sex with a partner who's HIV negative, the chances of transmission there. And the second part of the question was around the viral load and unprotected sex and what that has, I suppose, reinfection on the viral load. And the other one, the last part was about some drug called Tribus, which I'm sure, you'll tell us about it. So, anyone can go.
Okay, let me start. This is a fascinating part of science. Transmission is related very well mathematically to viral load.
Right.
For people that are asking what is viral load is the number of copies of HIV inside a drop of blood. And we can count the number, and the higher the number becomes in a person, the more likely they are to transmit to another person. There are some people that think that if you have sex with someone who's HIV positive, you will automatically get HIV. There's a 100% chance that you will get HIV. That is not true. The risk depends on what the viral load is like, and there are other factors that will also determine the transmission event happening or not. For me, one of the most elegant pieces of science is a study that is called HPTN 052. And that is a study that showed that if the positive partner takes ARVs and suppresses their viral load to undetectable, they're not able to transmit the virus to a negative partner with unprotected sex.
This is probably related to the issue of people that would say, well, I was HIV positive and my viral load was X and so on, and now I happily have 2 children.
Yes, it's the same principle. So
Right.
if you cannot transmit to a partner, you cannot transmit to a baby as well.
Right.
There are overwhelming benefits of anti-retroviral drugs, and these 2 are the most compelling, that if you use anti-retroviral drugs,
Yeah.
you're unable to transmit to partners and babies.
Okay, very quickly on that Tribus issue. What is Tribus?
Tribus is an antiretroviral drug. It's 3 components of drugs into 1 tablet, also called the fixed dose combination. The original drug is called a tripler. And this is the 1 pill once a day drug that many people talk about. It is the first line standard of care in this country and in many places around the world. It's a fantastic drug because you only need to take it once a day. There are some people that that have some side effects from there, and that can happen with any drug.
As with any other
drug.
Okay. All right. Perhaps let's, before we run out of time, let's just focus on prevention of HIV. Perhaps let's get it from a government perspective in terms of prevention. I mean, clearly we've spoken about the successes that we've achieved and the fact that we still have some challenges. Let's talk prevention. How is government looking at the whole notion of prevention?
The whole notion of prevention now, based on the information that we've got, which Professor Geoff spoke about earlier, we know that the group that is at risk now, the 15 to 24-year-olds, our focus is going to be on that group. Plus other groups, men who have sex with men, sex workers, we know that prevalence and incidence are high in those groups.
Right.
So we're going to be focusing on that going forward. For the young group, we recently launched a big campaign called She Conquers, and that campaign is going to address 5 things. It's going to focus on reduction of HIV. We're going to be looking for these older partners of these younger girls and ensuring that we test them and immediately put them on treatment. If they haven't been circumcised, we'll offer them circumcision. But coming back to the younger girls, to deal with the issues that were raised earlier, this program will address economic empowerment as well, reduction of new pregnancies, and ensuring that we deal with gender-based violence, very high levels of gender-based violence in this country. So we'll be focusing on this group in the schools, outside of the schools, in the community, and anywhere. In the TVET colleges, that's where we've got about 4 billion dedicated to this program, and also supported by some of the other partners like the US government and other partners. So we will be focusing this time for impact. We will
Are there
not
still
be
issues around awareness and stigma and that sort of thing?
Yes. The new strategic plan will contain a huge component also on behavior change.
Right.
Because we need that consistently in people's faces, not just young people, but the whole of the country. Every citizen must be aware that we have to deal with this challenge. The issue of stigma, we did a survey through the South African National AIDS Council, and it was really a bit surprising that more people felt stigma internally. Something that our earlier guest spoke about, that the people who are HIV positive feel that they cannot speak about this situation. But a larger group of the people who are surveyed said that there's less stigma in their community and they're able to live their lives. So we need to also deal with those issues in a comprehensive way in our new plan.
Okay. Dr. Lahe, I'm going to ask you about the role of science in prevention. But before that, let's take Tammy on the line from the Free State. Tammy, welcome to Health Talk.
Good morning to you all. I've always wanted to check, when it comes to HIV and AIDS, you'll find that the concentration is mainly on black populations of South Africa. And then now, even if you get a documentary, where there is a television which will take those people, it's always black kids or black people. My question is, in fact, on the other side, you'll find that now the white people are on the doctoring the part on the research. Do we have many whites with the HIV and AIDS in South Africa, and what is the percentage thereof? Because even the presidency, you'll find that now, when they want to call everybody AIDS Day, they will always concentrate in the stadia of black people. Okay. Whether maybe the strength of the white power to say, we don't have AIDS, you people got AIDS. Can you assist me there?
Thank you. Interesting question. Dr. Simelela, perhaps this is directed at you.
Yes, I know. I understand, the question that he's asking. But yes, there are people of other races who are also living with HIV. In many of the groups that we work with, the South African National AIDS Council and across the provinces, there are many people who are living with HIV, of other groups, white people, who also live openly. And I don't think that we should be looking at this as something. Yes, no, it's not. Clearly, when we do the surveys that Professor Geoff spoke about earlier, a lot of people who are willing to participate are African people, and sometimes people who are white don't want to participate in the surveys.
Well, they happen to constitute more than 80% of the population anyway.
Yes, anyway. It reflects the demographics of the country.
Dr. Lahele, we spoke earlier about the role of science, of obviously the vaccine, but there are other methods. Yeah, do you want to quickly take us through what the role of science is in prevention?
So I think people think of prevention as abstinence, be faithful, and condoms, and those have been the classic ABC. And I'm delighted to see the launch of flavored condoms as part of the arsenal. But science has been bringing us even more methods that people can use. One of them we have talked about already, which is positive partners using anti-retroviral treatment to get their viral load down and prevent transmission to others. Yeah. There is something else that is called pre-exposure prophylaxis. Right. And that is a tablet that is now registered in this country, and it's taken every single day in people who are negative to avoid getting HIV. And the government is beginning to roll this out in demonstration projects, and they're very firmly supportive of the evolving science in PrEP.
What is the efficacy of the drug? I mean, does it...
That is a very loaded question because the efficacy depends on how well people take it.
Right.
So if you're highly adherent, it's going to work very well for you. But if you don't take it, it can't work for you, and that's what the studies show very, very clearly. Right. And then there is post-exposure prophylaxis, which is taking antiretrovirals for a period of 1 month after an exposure to HIV. Yeah. And that is also now available in our public sector clinics. It used to be available only in very certain circumstances, like to healthcare workers after a needle stick, or to victims after sexual assault. Yeah. But now it is available to anyone that has had an exposure.
Okay, so I'm sure this will lead us obviously on to the next topic we want to try and look at, and that is treatment, but that after the break. And I know that we have Shahim on the line. Shahim will take a question immediately after the break. Please stay with us.
MedShield, embracing our members in good health since 1968.
16 of South Africa's celebrities were battling it out for 40 grand at the 5th annual Celebrity Cook-Off in Witbank.
We look forward to welcoming everybody to Ekhuruleni because this is the place of coal.
For a starter, I'll give you guys 45 minutes to prepare, and the main course will be 1 hour 30 minutes.
The team name is Iniqua Stars, the clever choices.
Yes! Maniora pizza.
3 Michelin stars.
Yes!
Like a niece, 2. Drum roll.
Swami and the defending champions are the Michelin Stars.
That's Trends Travel every Sunday, 12 to 1 p.m. on SABC News.
If we're talking health, then let's talk seriously.
Welcome back. We're talking HIV and AIDS, and we're now talking treatment. But earlier on, we had a call from Rebecca that fortunately somebody else heard a lot better than we did. We'll come back to that just now, but we have Shahim on the line. Shahim, welcome to Health Talk.
Yeah, good morning. How are you today?
Good, how are you, sir? Your question or comment?
Yes. So I want to find out, I have a HIV positive person.
Yes.
All right?
Yes.
And according to the viral load, as the doctor said, is cannot be detected.
Yes.
Right?
Right.
But anytime I have like a kind of stress or some pressure,
yeah,
I always have this reoccurring genital herpes. What should I do about that?
All right. Excellent question. All right. Do you want to take that? But maybe let's park that. Come back to Rebecca, who asked the question around medical aids or specialists prescribing certain drugs that medical aids then reject and offer her cheaper versions. I think that's what she was saying. Is that correct? Yeah. Your response?
No, I think what she meant is that what they do, which is a policy for many medical aids, is they'll give you what we call a generic. A generic is the same type of the drug that would have been prescribed by the specialist, but cheaper. But what we want to affirm with Rebecca is that the generics do work. We use some of those in the public sector.
Right.
So she mustn't fear about the fact that it causes complications. Right. Those drugs are registered, they are proper, and they work.
Okay.
And
it's exactly the same drug, except it's got a different name.
Yes,
All
it's
right.
cheaper.
Okay. Dr. Leha, let's get to Shahim's question around
herpes simplex virus.
Yeah.
So first I just wanted to say well done on being virally suppressed on treatment. I always think that is something that we have to cheer on. Herpes simplex virus is something that is different from HIV, and once a person has herpes simplex virus in the body, it stays in the body. So it can come up every single time a person is stressed or is ill, I think a good idea is for people who have herpes simplex virus to consult their doctor within the first 48 to 72 hours of showing the symptom again, to get a tablet that can suppress the herpes simplex virus again.
Yeah. But it's not, the important thing here again, it's not necessarily related to HIV.
No.
Even somebody who doesn't have HIV can have recurrent herpes simplex virus. Okay, so let's talk about then treatment. Clearly, perhaps let's start with you, Dr. Simelela. I think we set to have the world's best, ARV program. Perhaps something to celebrate?
Well, I think it is. I mean, if you think about the fact that we had less than 1 million people on treatment, some couple of years ago, and we managed to enroll so many people onto treatment is a success for the country and has led to longer life expectancy. The important thing I think we need to realize is that we're going to have to put more and more people on treatment. With the estimate you referred to earlier, 7 million, we've got to get those people on treatment. Right. It's going to be a tall order.
So currently we have approximately how much? What percentage of everybody? We have about 3.8 million?
3.7 million.
3.7 million,
on treatment, and we've got 7 million people
Yeah.
who are living with HIV.
Okay.
So we've got to get the other 50% more or less onto treatment, which is very, very important.
Right.
But we've got a plan, as Professor Setswe said, to succeed, to remove AIDS as a public health threat.
Yeah.
We've got to achieve the 90% of people who have HIV know their status. Those who know their status are on treatment, 90%, 90% on treatment, virally suppressed. Then we will not have further transmission. As my colleague has said, we will know that we are succeeding as a country. It's not only the effort that must come from government. The scientists are here. The people who need to take the treatment must do that, and we must support one another. This is a call for the whole country. And we've triumphed before as South Africans. I think with this epidemic, we should be able to get under control.
Definitely should. Perhaps let's try and understand a bit more about, obviously with long-term treatment or chronic treatment, so to say, adherence. People don't like the word compliance, but adherence is an important one. Just take us through those factors that at least that promote adherence going forward.
Well, I can tell you what doesn't promote adherence.
Right.
And there was an interesting study that showed what was less influential were things like drug side effects or things that we normally think will prevent adherence. But what turned out to be really influential are logistical things. Right. So having to come to the clinic every single month and collect tablets and wait in the queue sometimes results in people losing half a day or a day of work. Transport issues up and down to the clinic every single month. It can cause a financial burden. And there's obviously time burdens associated with that.
But also the whole new formulation of drugs has helped, isn't that so?
Yes. That has definitely helped. Taking one pill once a day is something that is the east thing for people to do, compared to multiple pills that had to be taken twice a day, when I started out.
Okay, Dr. Simelela, I mean, there were reports, there and there about stock outs and that sort of thing. How are we doing in that regard?
Well, I think the issue of stock outs, the department is dealing quite efficiently with it. Nothing is ever perfect, but there is a system now that allows people to immediately alert the department if there is a stock out. There is a unit within the department that tracks this, and we also have activists on the ground, Treatment Action Campaign and others who are working with us in SANAC who let us know about this. The issue of adherence, I just want to go back to the fact that now we've also got a chronic dispensing system. People can get medication in the closest facility. It doesn't have to be a clinic, clicks, spa, wherever. And there are a lot of people now who are doing that. We've got adherence clubs started by people living with HIV, being supported by the state and many other NGOs. And these are things that we're trying to do as much as we can to improve. And what we found is of the people who are on treatment, those that do come back, 80% are virally suppressed. And more. So, when you do take your treatment, as Prof said, it does work. Okay.
Well, Dr. Lahe, Director of the Perinatal HIV Research Unit based at Ekhuruleni Hospital, and Dr. Nono Simelela, Advisor to the Deputy President of South Africa. Well, thank you so much for your contribution. Thank you so much for your time. It's a pity we didn't have enough time to talk about the vaccine, but I think that insert did justice to it. Well, all right, folks. Well, that's it for today, and join us again next week on SABC News, same time. Continue sharing those views and comments via our Facebook page, SABC Health Talk, and follow us on SABC at Twitter at SABC Health Talk. Remember that this show is repeated every Saturday at 2 p.m. and Thursday at 5 a.m. I'm Dr. Salom Dang. Thank you so much for watching, and thank you for your calls.